So good afternoon, everyone. Welcome to today's Maternity Action Plan session titled After the Birth Expert Conversations on Postpartum Wellness. My name is Maxilia Desir, and I, along with my colleague Kate Shamzad, will be guiding you through today's program. So before we start, a few quick housekeeping notes. We ask that you please remain muted unless speaking. Please take time to introduce yourselves in the chat. Please highlight your name, organization, and email. And please note that this session will be recorded. We aim to foster meaningful dialogue and actionable insights on postpartum wellness. And we're recording this video as well, so if anyone wanted to go back and look at this, or someone wanted to attend this and wasn't able to make it, you'll be able to have access to that video as well. So let's get started. First, we'd like to talk to you a little bit about MAP. So, next slide, please. So the New Jersey Healthcare Quality Institute, in partnership with many organizations and in various individuals across the state of New Jersey, came together to create what is now known as the Maternity Action Plan. It's more commonly known as the MAP, but in July of 2022, it was established. And MAP, if you did not know, is a holistic approach to making New Jersey the safest place in the nation to give birth and raise a child. It provides frameworks for reforming payment systems in the healthcare system, improving community-based social services, building the maternal healthcare network, and collecting and using that data that we collect for the good and using it for accountability. So next slide, please. So the evolution of MAP is quite interesting because in 2023, we launched MAP into action, and similar to today's session, we hosted a virtual work session, and we would feature subject matter experts from various sectors, including healthcare, community organizations, MCOs, and then we would share recording and resources of our work session series with the public. And we've held over 6 different in-person convenings, just convenings in general, and collaborated with various attendees. And it's just something that we take a lot of pride in. We hope we can all continue to work together toward the common goal of optimal maternal child health care within the state of New Jersey. So next slide. So I just wanted to briefly go over the agenda with everyone. So we are going to be having some amazing speakers. They're going to highlight various topics. We're going to talk about clinical perspectives on postpartum mental health. We'll talk about postpartum and lactation support, and then we're going to have a discussion on early intervention in postpartum care. And we're going to highlight the Family Connects program. And then we'll have a facilitated Q&A. Feel free to put questions in the chat or unmute yourselves during the Q&A session. Write anything down if you need to. But yeah, let's get right into it. Okay, so as I mentioned before, we have some phenomenal speakers. I think it's important to highlight their accomplishments and all the great work that they have done, but because we are limited on time, I won't be able to read every single amazing thing about them. So just keep that in mind, that they have phenomenal credentials, and please try to connect with them afterwards if you want to know more about the work that they do. So our first 2 speakers will be Dr. Nicole Lamborn and Lisa Treyman. So Dr. Lamborn is a Virtua Vice President of Clinical Operations for Women's and Children's Services. She oversees the OBGYN departments and related women's issues for the health system while working in standardized treatment guidelines, policies, and procedures within the service line. She provides supervision of quality practice patterns and trends, CMS indicators, and the management of physician contracts. Dr. Lamborn works collaboratively with the administrative team established for the Women's Health Service line for strategic planning, which has included expanding midwifery services, doula care, and behavioral health. She is passionate about women's health and meeting the comprehensive needs for women in our community. Something else to note is that her most recent initiative was launching the prenatal mood and anxiety disorder program for Virtua Health. Lisa, who is an RN, is a survivor of postpartum anxiety and OCD and a nationally recognized advocate for maternal mental health. She is the founding director of the Center for Paternal Mood and Anxiety Disorders at Monmouth Medical Center, New Jersey's first and only intensive outpatient program for mothers and babies, and one of just 20 nationwide. Incredible. So Lisa also co-founded the Bloom Foundation, a nonprofit connecting families with evidence-based mental health care. With over 2 decades in maternal health, she has been leading a voice in policy advocacy and clinical innovation. So I will now pass the floor on to Dr. Lambourne and Lisa. Thank you so much for agreeing to do this. Thank you.
Thank you. Thank you for having us. We are excited to be here with you today. I know the definition here, the title is expert conversations. I have been practicing for 25 years, and that is really my only claim to fame when it comes to this. And having 3 children of my own with various, issues related to mood disorders during those pregnancies, after those pregnancies. And I really defer to Lisa as really the content expert here, but I'm really here to just really promote the awareness around perinatal mood and anxiety disorders, as well as speak to the importance of every healthcare system making this a priority and, putting resources behind programs like our 2 organizations have, because it is much greater need than we're even aware of. Most of us are only scratching the surface of what's out there and the needs that are present. The first thing I want to draw everyone's attention to is the title for today is really focused on postpartum. And I really think the better way to look at this is perinatal, and really realizing that this starts well before the postpartum visit. And the more aware and attuned we are to the issues early on in the pregnancy, pre-pregnancy even, the better our patients will do. So, perinatal is a much better, we've always talked about postpartum depression, and that's where our attention has always been. But it's really perinatal, and it really, again, the earlier we can recognize it, the better everyone will do. So I will send it over to Lisa.
Thank you for having us, Max, and the initiative. And Nicole, I feel like you are a soul sister, and I'm so happy to meet you in person. We speak exactly the same. You could turn the slide to the next one, but I will tell you that I have been beating the drum for it being the wrong name, whether we're talking about after birth or during pregnancy, or even during the planning and half or unplanned of pregnancy. Calling something postpartum depression is why people aren't getting diagnosed or aren't being identified and aren't seeking treatment. So this is so great to see that you're doing this and that you have a program. I'm so thrilled to be now one of 2 in New Jersey. That makes me so happy. So we're going to talk about what are perinatal and some risk factors, and why the heck you should listen to me. Very much like Nicole, I really come exactly 24 years experience, and I'm a mom of multiples. I have triplets who were born 10 weeks early, and they were in NICU, and I had infertility, and that goes right to the risk factors, where if someone had paid attention to me when I was pregnant, they would have seen I was a huge setup for any of the perinatal mood disorders. So I'm a big believer, huge believer in preventative care as opposed to putting out the fire. And I refer to it and define it exactly the same way, that perinatal is the period from thinking about having a baby to the first year after delivery. It's a long time if you're involving infertility, if you're having a loss in between there, and if you're finally having a viable pregnancy. Mood and anxiety explain it wonderfully, as opposed to just the word depression, which leaves out 9 out of 10 symptoms and feelings. So definitely mood is the mood. You're irritable, you're angry, you can be depressed, you can be anxious, you can have panic syndrome. And anxiety really hones in on which different kind do you have. PTSD or OCD or generalized, or coming to the ER with panic in the middle of the night. And disorders, impairment of daily functioning, and I always say meaning to temporary and treatable, giving people hope that it isn't a diagnosis for life. that once we see who you are and get you the proper treatment, everybody gets back to themselves. And sometimes themselves, I think, Nicole, you may feel this too, is someone with a general level of anxiety or a heightened sense of sensitivity or empathy, but not being able to not function on a day-to-day level. But we can get you back there with the right treatment. Next slide, please. Oh, the stats. Don't we love the stats? And I feel like these are just, first of all, right? And I know I've used the same. In 2008, there was a study that said
Right.
that PMAD is about 20 to 25% out there. 2008, I mean, in 2008, I had an 8-year-old. That's just silly how long ago that is. But it speaks to how little studies are done on women in general and how few studies are done in women's mental health. I mean, we have two strikes against us there. And I bet
It's
Nicole,
also the diagnosed, those that are diagnosed, you know, the real prevalence is so much higher than that. I would argue that, you know, in my experience from my own patients, my own family, I would say almost everybody goes through some type of mood transition. You know, they used to call it baby blues, but you know, it's really somewhere along this spectrum. And I would argue that almost everyone goes through this, and it's just a matter of whether or not they speak to it, they speak out about it, they seek help, or they admit to it. But I would argue that almost every patient goes through some form of mood transition.
really do have to get a show for the road. I would argue that every patient has some type of adjustment disorder from being pregnant and or having a baby on a spectrum of 1 to 10, just like we say so many things are now. And along with being able to identify it, is your culture, your family, your friends able to, is it mental health an issue? Is it something that's secret? Is it something you feel less able to talk about than a cancer or a diagnosis of something where it would be accepted? Because we're fighting that too. But I would say so similarly that it's ridiculous that everybody has some flavor of it. And depending on who they tell, what they say, and what they admit to is how we're going to have to treat them. PMAD rates have increased, I guess, definitely since COVID. I mean, during COVID, it was the perfect setup, right? Everyone was stuck inside, isolated, anxious. Certainty was nowhere to be found. It was like everyone had PMADs. And then the women who went in and had to deliver on their own, I mean, it was a perfect setup. Our volume tripled. And of course it did. Like how I love the people that were like, well, I just shake my head. 23%.
Yeah, I think we took away a lot of coping mechanisms by separating everyone, you know, the connections and having personal support, having interpersonal interactions really helps to mitigate some of the symptoms and the issues that people face. So by separating everyone, keeping them isolated, not having them be able to speak to somebody else and just help commiserate with fellow people that are going through similar things really increases the rates of all of the mental health issues that we saw post-COVID. I think the rates increasing is multifactorial. I think it's, you know, obviously increased awareness, finally increased screening and diagnosis, but definitely the coping skills and the ability to utilize resources, access resources, and just have the support systems out there is lacking from what it used to be. But I think a lot of it is just also awareness and people admitting to it. I think when I look at my mom's generation, you know, people just didn't speak to that. You just sucked it up. So I think that's a big part of it too.
Huge. And I have, and I'm sure you do too. And I can't wait to hear about your program. Like I'm just personally so excited to hear it and get your direct phone number to help you fill that up really fast. That the moms that are here, you know, the first word they use is, I just don't feel like myself. I feel so alone. I didn't know it would be so lonely. It may not be isolated, right? And we're using a word. And so listening or having the time to, you poor doctors that are given time limits on seeing people, like it's not fair. So we have to have such a multidisciplinary attack for identifying and then holding and then getting to the right treatment. And New Jersey is so set up to do it. I mean, we were the first state doing the screenings, but the screenings led to nothing. We referred where? That was just embarrassing. So this is a much better year to be involved. We do know that most often PMADs start during pregnancy. I feel like a lot of times the moms will say they were fine, and then when they think back or I ask them, they're like, oh, that sounded really anxious. And I'm like, But, and so anxious in my family might be worrying, and anxious in your family might be overreacting. You know, like there's all these different words too that families, cultures, friends, people use. So worried or anxious might be two different things when really you're trying to say the same thing. Massively underdiagnosed and undertreated. I think I was at 75%, the one I use, go undetected, that even get known, admitted, sought. I think I have can you help me with? And then of that number, 85% go untreated. I mean, I just cannot imagine another illness that we could put that number up there and not be brought to court.
Right.
Well,
Yeah,
it's just,
and it's another
wow.
area that we see the racial disparities, it's another area that
Oh,
we
yeah.
see the minorities, Black and Hispanic especially, have actually higher rates and unreported rates and untreated rates. So it's another area that we are failing our minority populations.
Absolutely, absolutely. And transportation too, and childcare, like it all falls into it. So that's, I think we all agree on that. And the next screen is risk factors. I bet you do too. I go on and on and on about this, and they are all there for you to see. And I know the PowerPoint will list them for you and it'll be available. So I won't go through each one, but definitely having a history of prior PMADs, having a history of hormonal sensitivity, PMDD, IVF, having had a loss, having multiples, high life stress. Do you know anyone with low life stress right now? All the people who love to move into a new house while they're pregnant and change their jobs, undesired pregnancy, comorbidity conditions. And I've added on since being here from being with these people, because 80% of my patients are teachers and nurses and social workers, that it is type A perfectionists, empathic women who have always been the help and are unable to ask for or accept help. I'd love you to tell me what your thoughts are on that.
Yeah, I agree. And I'm, the parental leave, because a lot of people that are in those kind of jobs don't take enough time for themselves and time after the baby. So I'm happy to see more and more people taking that time. And I
Yeah.
know we're short on time for the slides, so everybody will get these slides because we kind of have to speed through them, I think. So next slide. I think the important thing to remember is that everyone is impacted in the family, the whole family, obviously the birthing individual, the mother, the child, other children in the family, the spouse. It affects everyone.
It affects the dog,
Next slide.
right? Your first baby.
Yeah, and I think we can skip over some of these adverse health outcomes. Again, we can send them out. It's just important to look into the why behind this, why this matters. It's not just about treating mom after birth. I think, again, we all focus on the postpartum depression issue. But again, this is a pre-existing condition for most people in terms of their feelings, their emotions, dealing with their moods, dealing with anxiety from before pregnancy, during pregnancy, and certainly after. And it does have health implications for mom and baby, and it's important that we address it. And the more, just like any illness, the more we treat it, the more we can help address those issues pre-pregnancy and in between pregnancies, the less likely we have some of those adverse effects in the following pregnancy. Next slide.
Right? Imagine getting ahead of it. I always say that. And this is the worst thing that can happen, and it happens every day. It happened here to us in our practice in January. First time in 10 years.
Awful. Yeah, I mean, this is what everybody's always worried about, and whether you're the family member, the individual, the caretaker, the care provider, this is what we all want to prevent. So, making people feel like they have resources, making sure that they're connected, really helping to teach them how to reach out and showing them that there are people there for them really is all the best that we can do to help prevent this outcome.
And really hearing them when people, I always say when someone is telling me, like really being available to hear what they're saying, like opening the door for a woman, you can feel that she has more to say and saying like, you can tell me what, it's nothing I haven't heard. Like, you're okay. I'm not calling the police. I just want to help. How, what are you feeling? And you would be surprised and saddened, but it gives you the opportunity to offer help to women you didn't even know this was what they were thinking. And everyone knows someone in their circle who has taken their life at some point, with maternity, postpartum, suicide, prior history of, and it's not talked about. And that ruins every generation feels that. So we can't have that happening. It can be preventable.
And I think to your point earlier, OBGYNs in general are so rushed, have such limited time that too many times they don't really want to know this, because if you ask this, you have to do something about it.
Nicole?
And we don't often have the resources to refer people to, as you said also earlier. So it's like, okay, if I ask this, first
Then
of
I
all,
have
if
to.
they say anything except no, of course not, that's going to derail my entire day, my entire schedule. Plus, I don't even know where to send them.
Right.
So too many times, this issue is not even dealt with head on, even attempted to be uncovered, because there's not the
They
time
do.
or the resources to give to it.
And I can't blame them. I remember learning to do the Edinburgh in 2008 or whatever, right? And as a nurse in 2008, who didn't even feel like I had any right to raise my hand, I was like, well, then what did we do? And they literally were like, will you refer them to this phone number? I'm like, who is at that phone number? And they're like, that's where they get help. And I'm like, oh my God, this is like buying a car. Who's at the phone number? And that's how this center came about, because I don't think anyone was at that phone number. And how do you treat for something and ask about something and then be like, good luck with that, without giving them reliable, ethical resources? It's just upsetting.
I know we're tight on time, so can you just jump to slide 13 and we'll just talk a little bit about the screening before we open it up for. So again, I encourage everyone to look through the slides that they'll send out. What we're talking about in terms of not wanting to address suicidal ideation also starts with not having the appropriate screening throughout. So, every woman, every well woman visit should include some type of mental health screening, and ACOG endorses that. And certainly throughout the prenatal time period. So at the prenatal visit, at different times throughout the pregnancy, and then certainly at the postpartum visits. Our pediatric colleagues have certainly outpaced us with this. They were the first ones recommending screening, as is true with most people once they become a mother, you become second. And we, as a healthcare specialty, a healthcare field, we have really endorsed that mentality of mom comes last by not even seeing her for 6 weeks, by not addressing that there could be any issues from birth until 6 weeks. It's all about the baby. And we endorse that by our behavior and not seeing them and screening them. And, peds started to say, hey, mom is just as much my patient right now. She is crying to me. She is saying the baby's not feeding well. She's anxious. What do I do with mom? And they would reach out to the OB, and the OB was like, I don't know, don't ask me. And it just became, this lost in the gaps. And
Yep.
now finally, ACOG has stepped up and said, no, this is really our responsibility. The patient is still our patient. It's not delivered and done. We have to be responsible for screening them, taking care of them, and connecting them with the resources they need.
And it would be, I know you're gonna say this too, it would be so wonderful to equalize mental health and physical health, and to be like when you come in and you're past the point of 12 weeks and you're getting your glucose tolerance test, you're gonna be here for a little while anyway. So let me have you fill out this risk factor sheet. Do any of these apply to you? Boom. And have you do a Edinburgh or GAD or PHQ-9, whatever you want to pick, to see what their baseline or where they're coming from. But again, then they have to have a person at that office to follow up, because they're going to be inundated with people who are saying, yes, or I feel this way. And then where do you go and refer? And there are nearly not enough mental health technicians out there to handle the load I have now. I have 8 full-time therapists here and 3 APNs, and we have a wait list of 14 right now.
Yeah, we have similar, we only opened about a year ago, and we just exploded from the time that the doors open. And we started with 1 provider, we're up to 4 providers full-time, LCSWs to provide counseling. We have NPs to help with medication management, but it's just, we still have an incredible wait list. So resources need to continue to expand, systems need to invest in this. I feel that insurance companies are starting to really listen and respond with reimbursements. Not everyone, but it is improving and really helping us be able to provide these resources. So I think everyone has to really make this a priority as we move forward to really help everyone. As I said, it affects the whole community, not just the patient themselves. So I know you guys.
And not just right now, it's really generational. I mean, the impact of suicide alone, but as long you can go to the child and their behavior and all the instances that come with that, or attachment or not attachment or hypervigilance. I mean, there's so many flavors, but they're all not good.
Well, thank you so much, ladies. You guys are having such a robust conversation. I found myself learning a tremendous amount. Just to field some questions your way, Dr. Lambourne, what have you found to be the most significant clinical challenges in diagnosing or rather a PMADS? Like, how have you been able to diagnose that early on?
Well, it starts with building a relationship with your patient, your client, listening to everyone. I saw something pop up about lactation consultants, between doulas. We have such a well-rounded healthcare team now between our midwives, our doulas, social workers, lactation consultants. There's so many different touch points now for the patient, and we just have to be responding to those messages and be an open door so that people can send us those messages and feel like you're approachable to say, hey, I'm worried about your patient, and not be like, that's not my problem. So I think patients are getting more comfortable with sharing some of those thoughts and sharing how they're really feeling with somebody. Like, it not necessarily, maybe they don't feel comfortable with their doctor sharing that aspect, but they're going to share it with somebody on the care team. And we just have to be an open door to receive that message and act on that message.
Yep. And just like you said, I think taking, knowing you have 9 minutes, I mean, this is just such a, but sitting for 7 seconds and saying, how are you? How are you feeling? Like, instead of being up here with the board, knowing you have all that to do, but like, I've literally spoken and I'm like, just seven seconds, look at my face.
Right. And not be behind the screen. Nowadays, so many times providers are putting everything in the computer instead of making that eye contact with their patient.
They're being forced
looking at them.
Yep.
Do they have tears in their eyes? Do they look like they're going to fall apart? You need to address that, and not just because they say, no, I'm fine. Well, they're not fine. We need to dig a little bit deeper.
And only by seeing that can you say, you're not fine. I wasn't fine. Like, tell me what's going on. Just please tell me. But then backing that up with, I know where to send you, or I know where to start, or I know where to, a phone number. And often, like I found in the early years, I had to be the phone number. Like, I had to be like, let me call for you. Like, they're so far broken that fending for themselves is even overwhelming. And why shouldn't we be there to do that?
Yeah, I think that's an important point. And, listening to the doulas especially, they've been so good at following up on that, knowing that just handing somebody a phone number and saying, here, call if you have any concerns, it's not enough,
Not.
Again, I think using the full team and the resources that we have to help us get the patient connected to their care.
Yep.
Yeah, awesome. I love that answer, and I love the back and forth that you guys are having, like the camaraderie. You really can see the passion. Lisa, I have a question, and I think this can both apply to you. both, I wanted to know, given your experience creating New Jersey's first prenatal mood and anxiety disorder center, what does standard of care look like in practice, and what is the first step system should take to move in that direction? And Dr. Lambert, please feel
Nicole
free
and
to
I
jump in.
are writing the script right now. I think there needs to be, there was a rat czar in New York. I'm not sure what his salary was, but it sounded like a very important job. If we had a map czar here in New Jersey, there's a formula. We both have it. And to be able to roll it out as a policy, as a standard of care, as an expectation, and then it's not all put on the OB. That's not fair. That there is a team, a navigator, an identifier, a resource. And then together, we will make sure I don't see it as that hard. It's how many thousands, 100,000 delivery essential phone number. It all goes there. We disperse by county and we get to help everybody. And then we don't lose another mother.
I think it's just digging in and making it happen. We were very concerned about launching the program from a financial aspect.
Oh my.
Of course, we knew the clinical need was there, and that's what pushed us forward. And thankfully, we had a system that was willing to take the risk, even if it was not a financially beneficial or sustainable program, because they saw the need with the number of women that we deliver in our healthcare system, that regardless of what the cost was, this was something that we had to do. And if we had to supplement it with funding from our foundation or whatever it was, we were going to do this. And thankfully, it pretty much sustains itself. So I think that people taking the risk to see, okay, we can do this. No, it's not a huge moneymaker. You're not going to get rich off of treating women for PMAD, but that's never why you should go into it in the first place. So it is
a community
sustainable
service
model, and
it is a responsibility, right? Any hospital that's delivering, I'm amazed they all haven't been sued. If you're liable for preeclampsia when it becomes post-birth eclampsia, how are you not responsible? When my wife went to 12 ERs and she told everybody, I'm not okay. And they were like, you're too pretty to hurt yourself. That's a real story. And she took her life. She showed them. I know way too many of those stories, and I bet you do too. And the 300 women we see a weekend that are on a wait list, and financially, the same thing. We did the same exact thing. And they called us the field of dreams, that it just was, they were overwhelmed. But in my heart, didn't you, Nicole? I'm like, of course, there's nowhere else to go. How could everyone not come here? Like, I'm holding them back. If this was in every birthing hospital or within an hour, we had one per county, there were so many more jobs available.
I think most providers could tell you stories about how they spent hours just trying to find somebody that could see their patient, or had time or could fit her in quickly. And it's just an ongoing story that almost everybody. So if you've gone through that a couple times and felt that panic of, how do I get my patient the help that she needs? A lot of people will just stop asking or reduce the amount, because if you can't help the person, it gets very frustrating to uncover the problem, because then you just feel,
and even liable. Like I use the word responsible. Like if I see a mom at Target and I'm like, hey, you okay? And I pick it up and I look at her and she's going to cry. And I'm like, come here. Like, I have to help her as a human being. Like, I don't, like, just be a human. Don't leave someone out there like that. And it could be just like you're saying, there's virtual options now. There's telehealth, there is, but like, we need to pull it all in one place and meet it out. And the right people need to be in charge and need to be angry and motivated enough to be loud.
Yeah, no.
I can be loud. I bet you can too, Nicole.
my kids would tell you I can.
I mean, I thought that was great. I have one last question. If you have the ability to change New Jersey's current approach to mental health screening, how can we better support providers in referring patients to appropriate mental health services? So like, how can we better approach screening individuals, and what can we do to refer people in an appropriate manner?
If I could take part one, I would screen every lovely birthing person with the glucose tolerance test. If not before, right? But I understand too, the trial in 12 weeks and miscarriage and okay. But in those 12 risk factors, it's just like the Edinburgh. If you have 3, I'm going to give you a color. If you have 5, I'm going to give you, a red. If you have 10, I'm in your driveway. And then I know that I'm going to start this, this, and this. And also too, Nicole, we didn't even cover that medication is fully able to be taken. Risk benefits, it's risk, because if you don't take medication and you do need medication, your baby, your pregnancy, and their postpartum period is suffering anyway. So it's not that there isn't a benefit, it's that both have a risk and you have to weigh them.
I agree. What was the second part of the question?
I know, what was the second part?
How can we better support providers in referring patients to appropriate mental health services?
Having access. I think we've done a lot to require more screening in terms of ACOG recommendations, as well as, Medicaid, NJ-QIP. There's so many pay for performance kind of models out there that are measuring the screening for mental health, which is a huge part that's pushing people towards doing the right thing. And then just really making sure that we continue to invest in the resources so that, again, when you screen, there's somewhere to send them, there's somewhere to connect them with, so you're not just wasting everyone's time or possibly making things worse. There's nothing worse than saying, oh, you're not okay, I'm sorry to hear that, have a nice day. I mean, that's
I wish I
terrible.
could help. Oh my
Right.
God, imagine. Or even being the patient with, when we get so frustrated and I'm trying to find help for a mom in up north, I can't even think of the town with the P, Paramus. And I'm frustrated. I'm currently a little bit regulated and stable, and I'm not pregnant or postpartum or hormonally overwhelmed or sleep deprived times 36 hours. And I want to give up. How can we ask someone who's already broken to fend for themselves while caring for a newborn, while falling apart, to call these 5 phone numbers and no one answers?
Yeah, and I think the more organized the list of providers, the different cooperatives that
Same.
help us keep a list of what's available to patients and continue to update that like they
Yep.
do and get that out to the health systems, the providers, really helps to keep that fresh and make sure that all providers have that list in terms of knowing what's available in their area and where their patients.
And all the different pieces of it, just like you're saying, like a doula is, oh my God, life-saving. A woman showing up to a woman and putting her hand on her and saying, what's going on? And being able to fix or refer or validate. I mean, that's life-saving too. But I think that would be a full-time job to keep the list when, I'm sure you have a list, I have a referral list. Whew, that is like a every other Friday kind of thing. And, sometimes I hear back that who I referred someone to is not a golden girl and she comes right off. And then, I find someone else to put back on. But that would be like a full-time job to keep a New Jersey directory and all the different levels. Because I think a lot of people stick to OBs, right? But what if they're trained? Community workers. I mean, there's so many possibilities for humanity.
Depending on the level, of support that you need too.
Exactly.
That was an excellent point. I'm thinking, like, should we train social workers to be able to do that type of work? That's amazing.
We have trainings right here, and I bet Nicole does too. I can train your trainers to train people.
No, exactly. I think that's a wonderful idea. I'm thinking now, and I'm like, as someone who's really close with social workers and sees that work, what the point you're making makes valid sense and is wonderful. I want to thank you both so much for taking time out of your busy schedule to present. That was wonderful. I see a lot of engagement in the chat. I think you guys will get some questions afterwards, which I'm really excited to see. I will now pass it on over to Kate, who will be introducing our next set of speakers.
Thanks so much, Max, and Dr. Lambourne and Lisa. We probably could have kept going well beyond this full session with this topic, but I think bridging to our next topic isn't so much switching away, but just continuing the conversation, particularly as I see folks mentioning within the chat the real impact of those working in the community on mental health. And so I'm excited to move our conversation into talking about lactation support, including coverage and accessibility. And I know that we've got two great speakers here with us today. So I'll be joined by Ellen Mon and Felicia Patton. And let me give you just a quick introduction of them. Ellen is a retired attorney and international board certified lactation consultant with over 30 years of experience supporting families in meeting their lactation goals. Her journey began with the empowerment she felt overcoming breastfeeding challenges with her premature firstborn and two daughters. Ellen earned her IBCLC in 2001 and soon after shifted her focus from law to lactation full-time. She's worked in hospitals, pediatric offices, private practice, and WIC agencies, and served as a board member and past president of the New Jersey Breastfeeding Coalition. In March 2024, she became the state's first breastfeeding coordinator at Central Jersey Family Health Consortium, and in this role, she leads the implementation of the state's 2022 through 2027 Breastfeeding Strategic Plan, which we'll hear more about in a little bit, and collaborates with stakeholders to strengthen lactation policy across New Jersey. So welcome, Ellen. I'd also like to introduce Felicia Patton. She's a seasoned maternal and child health professional with over a decade of experience supporting families. Felicia began her career working at different maternal and child health consortiums within New Jersey, and inspired by her own breastfeeding journey and the disparities she witnessed amongst Black families, she pursued lactation consulting to be a voice and resource for underserved communities. She's worked in both the community and hospital setting, and she continues to lead breastfeeding support groups and educational presentations. She's currently building her own lactation business, Lalu Baby Lactation, and focused on empowering families and professionals through accessible, inclusive breastfeeding education. So welcome to you too, Felicia, and I'm so excited to get started. We will start with you, Felicia. Can you start by sharing what brought you into this work and how your personal or professional experience shape your approach?
Yes, so thank you for having me today. So 16 years ago, I gave birth to my son, my oldest, Jeremiah, and I didn't have the resources. I was very intentional about my birth. I had worked in the maternal and child health field, so I kind of knew what I wanted for my birth. So I searched high and low for a Black OBGYN. I was able to find one. And then I looked for a Black doula. At that time, doulas wasn't the latest thing. And so I was not able to find a Black doula. I also looked for a Black lactation consultant and could not find one in my area. And so I wasn't able to have those resources that I was searching for. So I had said I did not want another family to go through this experience that I had. I would want them to be able to have those resources. So I went and I got certified as a Lamaze childbirth educator, and I started doing childbirth education with families that looked like me so that they had the education about what a birth looks like, if that was, what they wanted as far as a birth. And then I just became so passionate about breastfeeding. And I said, this is really, really what I want to do. And so I became certified as a lactation consultant. And I just started teaching, started educating, started telling families about breastfeeding, educating families that looked like me about breastfeeding. And it is something that I love to do, something I love working with families to provide that resource to them. So I've been doing it for over 8 years now, and I truly, truly love it.
That's amazing. And I think the way your personal and professional stories are interwoven is so important because I imagine many have been in that position that you were in, those 16 plus years ago. And I'm excited to ask you, Ellen, to walk us through the origins of the breastfeeding strategic plan because I think we'll hear similar highlights. What motivated the development of this strategic plan and what stakeholders were involved in shaping it?
Sure, and thank you for having me. And I just want to add, Felicia, you love it, and your moms love you because I had the opportunity to meet some of them recently, and the care and the support you give is amazing. So happy to be here and to be here with Felicia. The breastfeeding strategic plan started in 2019 with some vision and some funding, and in the Department of Health, that there was a plan to create a blueprint of actions that everyone in the state could take to improve breastfeeding support in the state, to address the racial and ethnic disparities in breastfeeding rates, and to coordinate statewide action because, of course, many silos were doing great work, but we just weren't coordinated on it. There was that realization that needed to happen. So at DOH collaborated, the New Jersey Department of Health, that is, collaborated with New Jersey Breastfeeding Coalition and Central Jersey Family Health Consortium as primary partners. And the plan was created based on a number of actions. I came on board to be the project manager. And first thing we did is we had to scan what was already out there in terms of policies and supports for breastfeeding. Look at the data, see what the data is showing us. But in addition, we brought in key informants, many stakeholders, I'll talk about in a second. But we also did our own original research. We did focus groups around the state, 8 of them in English and Spanish. And the data there was so very rich with what our families told us they needed to have better breastfeeding support in the state. As far as stakeholders, wow, we ended up having over 70 stakeholders. And at first I had some trepidation. I thought, gee, people are so busy. I'm going to ask them if they would be a stakeholder. And everyone said yes. And then other people I didn't even know said, can I be on your stakeholder committee? I want to do something for breastfeeding. I want to be part of this planning. So we had our representatives from our sister Maternal Child Health Consortia, New Jersey Breastfeeding Coalition, state agencies, not just the Department of Health, but the Department of Labor, the Department of Banking and Insurance and Medicaid, New Jersey WIC, SNAP-Ed, representatives from the healthcare provider organizations, New Jersey AAP, New Jersey ACOG, the midwives, nurses, we had a dentist. We had hospital and community-based lactation consultants, New Jersey Hospital Association, Nurse Family Partnership. Wow, it was such an inspiring group. A Children's Home Society, we had Perinatal Health Equity and Chocolate Milk Cafe and the child care organizations. We even had representatives from employers, New Jersey Chamber of Commerce, New Jersey Business and Industry Association. We really tried to cast a wide net to that kind of socio-ecological model, all the spheres that touch breastfeeding, and we tried to get somebody there from every sphere. So it was a really great group. We hardly had a room that could hold them all.
Wow, that is quite an impressive list. And I think so essential and important that you included families because that's really, where you get so much information. I'm sure you uncovered a lot of things to work on, but Felicia, I'm wondering if you can tell us how families are navigating the gaps to receiving lactation support. How are they meeting their breastfeeding goals within the community?
So I think a lot of families now are really using social media as a way to navigate some of those gaps. They are joining, Facebook groups for moms, lactation groups for moms, Instagram, TikTok, even watching YouTube videos. When I do ask families, have you taken a breastfeeding class? Several of them say no, that, I watched a couple of videos on YouTube, or, I'm in a Mommy and Me, group on Facebook, or they rely on family and friends to kind of give them the information about breastfeeding. Also, some of them are in support groups. I facilitated a breastfeeding support group, and so some of them are in that group, so they use that as a resource. And sometimes they do ask questions specific to their care, their breastfeeding journey. So I think that's another way they're navigating. If they can't get a lactation consultant or can't find a lactation consultant that is in their area, there's still not enough lactation consultants in the state of New Jersey for the amount of births that we have in New Jersey. So they may not be able to find one in their area. They also may not be able to find one that looks like them. So if that is something that they want as part of their birth experience, their postpartum care, and they can't find a lactation consultant that looks like them, then they may navigate to a breastfeeding support group. They may navigate to Facebook. They may navigate to YouTube. So I think that's how they are navigating those gaps in the lactation support.
Yeah. That's a great point that you're making, that it's so important to be able to find someone in the community who looks like you, who understands you. I'm wondering if you both could touch upon the role that cultural humility and community trust play, especially in effective lactation support.
Yeah, I think trust is key, right? When I facilitate the support groups, I can see the tension roll off those moms, or when I go into, I'm going into either home to talk to a family and they see, and I look just like them. I can relate to their experience. I can see that they're comfortable with that, and then really showing them that I have their best interest. I think that that is key as well. And that's how we gain that trust. And then being consistent. I think with support groups, being consistent and showing the moms that you're going to show up. That is definitely key with gaining that trust. And then not having your own agenda, acknowledging the biases that families have and supporting them, honoring their choice and listening to them, respecting their choice. Because not everybody wants to exclusively breastfeed, right? Some families may want a combo feed. Some families may want to exclusively pump. So I think honoring their choice and then working with them from that point, I think builds upon that trust in that family. Then also their village, right? It's not just the one person, the pregnant person, the postpartum person, their village. So gaining the trust of their village, their mom, their grandmom, the auntie, who's going to be watching the baby when you return back to work, getting that person on board as part of their village so that now you have trust, not just with the postpartum person, but you have trust among their village. So imagine what that will look like in 2 years and 3 years that you have now become a part of their village. So I think that that is key. And once you have that trust with the family, it just builds upon so much of their experience, right? And so when they decide to have either a second or a third child, they'll come back to you because they trust you.
And I would just add to that, and though 100% agree with everything Felicia said. From the breastfeeding strategic plan and what we've been trying to do, recognizing that that trusted community support is so very important. We've been working closely with New Jersey WIC, and we know that the WIC breastfeeding peer counselors are trusted ambassadors. They're members of the community, and they provide that same non-judgmental breastfeeding support. When we started, I found that there was just such a demand for more education. And we looked at the other state programs, home visitation programs, and we've been creating education, lactation skills, and just general lactation education for other trusted community resources, the community health workers, the doulas, and our great Family Connects nurses as those programs roll out in the counties. We've been creating and starting to roll out lactation education to further support those trusted community resources.
Yeah, to really grow the individuals beyond just lactation counselors who are available. That is a smart strategy. Are there other strategies from the breastfeeding strategic plan that have been early successes that you want to touch on?
Yeah, so of course, the strategic plan was released in 2020, and I didn't come on. I've been working with my team members for just about a year. So probably we're still trying to gauge the impact of each of our efforts. So time will tell. But some of the things that we've been really looking at is we've been really, working on collaboration with state programs to extend, kind of expand that lactation knowledge, to raise awareness of the resources that we have and to help foster more resources. I'll talk just about that in a second. But a couple of things that we've done, we've drafted a breastfeeding bill of rights, which we're waiting for some finalization of some New Jersey hospital regulations to get that out there. That would be for use in hospital and birthing centers and also during prenatal education. We have an exciting new collaboration with OBs and prenatal care providers through the New Jersey Obstetrical and Gynecological Society, because there's a new state law that requires that prenatal care providers provide their patients an opportunity to create a personalized postpartum care plan that includes all those things, all those touch points that patients need, that the medical home and other information. But included in there is a requirement that patients be given sufficient information about lactation and breastfeeding to be able to make an informed choice. So we've started a partnership with some OBs in Hackensack Meridian and the Hackensack Meridian Medical School to create a template that prenatal care providers can use during prenatal visits in order to get those touch points that, here's a place where breastfeeding education could be provided, or just, starting the conversation, honestly, because we know from our focus groups that our families said, gee, there weren't any conversations much during their prenatal, care about lactation. But really two other things. We worked with a collaboration of people to launch the first breastfeeding, New Jersey's first baby cafe in Camden, New Jersey. That's in-person drop-in breastfeeding support. And then we're soon to launch, just a little preview of coming attractions. This summer, we'll be launching a breastfeeding media campaign, including a statewide breastfeeding website and some breastfeeding videos to address, just as Felicia said, so many of our moms and birthing parents are getting their information from social media. So we want to provide some of those short hits, 30 to 60-second videos also to provide breastfeeding support and messages out there featuring real parents.
Mhm.
That sounds amazing. Ooh, it's echo. I'm gonna. All right. Okay. Things sound better on my end. Thanks. Sorry about that. It's interesting because both you and our first speakers of the day really are clearing up this misnomer that things that we talk about as being important in the postpartum period have to move back to the prenatal, point of view. And so I'm just thinking, as you're sitting there sipping your delicious glucose drink, watching some of those videos at that point, because you are a captive audience, might be a nice thing to add in. But there are so many pieces I think that the average layperson doesn't know about breastfeeding. And I'm wondering for both of you, what do you think is the essential information that policymakers should know about the lived experience of breastfeeding families, both in that prenatal period and postpartum, so that they can support lactation support? Thinking through really any of the facets of where you might meet a policymaker and talk to them about this.
Yeah, I think the biggest thing is normalizing breastfeeding in all perinatal settings, before a person gets pregnant, all the way through the postpartum period. So in pediatric offices, even in the grocery store, home visitation programs, the federally qualified health centers, I think in all settings, if breastfeeding is normalized, I think families will get the education and the resources that they need. Being creative with policy, finding, those policymakers, creating policy that's going to work with families is more than just giving a mom a free pump. Like, how is she going to learn how to use that free pump? How is she going to learn to utilize that free pump? And then what happens after? So I think it's more than just, putting something quick together and then just, passing it. It's more than that. And then more opportunities for the interdisciplinary team to, talk and come together, because it would be great if everyone talked to everyone. So if the OBGYN and the midwife talks to the lactation consultant talks to the pediatrician. And then, as our first speakers talked about the mood disorders, right? Having that part of their interdisciplinary team as well, so that everyone knows what's going on with this one family, right? And it's not just the one person that's giving birth, it's the entire family. So knowing everything that is going on, because we have the birthing person, then we have the partner, then we have the child, and then we have other children in the home. So I think if the entire interdisciplinary team is working together as a whole, there's so many things that we can do to keep families healthy.
Ellen, you're muted. I'm going to unmute you real quick. Oh, there
Okay,
you go.
great. Doing this talk right after the previous talk really is the perfect place. And there are so many connections, but that idea that, there's so many things. I 100% agree with Felicia about normalizing breastfeeding. In policymakers and others, and culture in general, still treats breastfeeding as a lifestyle choice.
Yeah.
It's a health choice, and it's a sexual and reproductive right. We talk about, oh, are you going to breastfeed or bottle feed? But during the pregnancy, the breasts are going to change. There's no choice there. It will happen. Between 16 and 18 weeks of colostrum, pregnant people will start making colostrum between 16 and 18 weeks of pregnancy. What you're doing is, right after the baby's born, the decision is whether you're going to opt out. So let's turn around the narrative and look at it that way. Okay. Then beyond that, with regard to policymakers, always including the community in, we have some wonderful and dedicated and progressive policy making in the state, in terms of maternal child health. We all agree about that. Yet sometimes the policies are really well intended, but they don't nail it, or they're not as easy to implement as people think. It sounds very good, but when you get down to the grassroots, it's not working. And we do need the grassroots to be a part of all of the policy implementation, informing policy and that, and that implementation. What we heard during our focus groups and what we continue to hear from families is that community stigma is still a really big issue, that healthcare providers acknowledge, in care, that breastfeeding is the healthiest way for not only the infant, but the mother, but that there's still, that those issues in the community, normalizing. We need to think in bigger ways about not just the healthcare providers and what they're doing can put all the weight on them, or the families themselves, but everyone, but also bringing in employment and childcare, because we know that so many of our parents are going back to work so quickly. And while we have a great law in New Jersey, in the New Jersey law against discrimination, providing the reasonable break time and a private place to pump, that there's still a lack of awareness and there's still a problem with stigma in the workplace. So that's important, that we still need to address that and raise awareness and realize, help employers realize that it's actually a win-win to support your lactating employees. And then in childcare as well, we're doing some work on that with the Department of Children and Families with regard to trying to make the current childcare regulations more breastfeeding friendly. So those are just a couple of things. I don't want to talk too much because I know we have probably questions and want to make sure we touch on everything, but.
Yeah, thank you so much. You certainly have not talked too much, and again, I could listen to you both and discuss this all day, as I'm sure many of our participants can. And I see folks adding their experience into the chat. So thank you. Thank you for all of your conversation and for dedicating your work to helping individuals and their families experience breastfeeding in a way that's positive and supportive and healthy. And we are going to continue our conversations, but I'd invite folks who have questions for Ellen and Felicia to drop them in the chat. We're going to have a general Q&A in just a little bit after our next sub-session. But I'm going to turn it over to Max to introduce our next speakers. Thank you so much, Ellen and Felicia.
Hello, everyone. Thank you so much again for that amazing conversation. I feel like I learned a great deal, just even hearing like what can we do to combat breastfeeding stigma is just making sure that it's more accessible and open in areas I thought was great. And hearing the work that you both have dedicated to helping families, it's truly amazing. So thank you again. I have two other superstars coming up. We will be having Deputy Director Andrea Jackson, as well as Jenny Sherlock Loeb. So I'm gonna take some time to read their beautiful bios for you, and then we'll get right into the discussion. So Deputy Director Andrea Jackson joined the New Jersey Department of Children and Families in November 2021 to support the growth of the department's contracted family strengthening and prevention service array housed in the Division of Family and Community Partnerships. And she oversees the Office of Early Childhood Service, which is home of DCF's visiting programs and a key collaborator with other agencies and stakeholders on early childhood programming. Deputy Director Jackson also oversees the Office of Family Preservation and Reunification, which is building an array of evidence-based services to support both families and adolescents. Prior to joining DCF, her career focused on leading change efforts and program initiatives as both a government leader and public sector consultant, working with human service agencies in 25 states. She also holds a Master of Science in Social Work from the University of Wisconsin-Madison and a BA in Psychology from Indiana University, Bloomington. Jenny Sherlock Loeb is the Chief Clinical Officer at the cooperative, where she focuses on clinical education, fetal infant mortality review, and nursing leadership. Prior to this role, Jenny served as a childbirth educator and bedside nurse in labor and delivery and mother-baby. She achieved her Bachelor of Science in Nursing degree from Westchester University in 2011 and a Master of Science in Nursing from Drexel University in 2015 with a focus on nursing leadership and health systems management. Jenny is specially certified in inpatient obstetrics with subspecialty certification in neonatal quality and safety, and utilizes her clinical experience with the development of educational programs and initiatives. Recently, she was awarded the distinction of an Advanced Nurse Leader certification by Sonova, and she is dedicated to the future of nursing profession and its impact on the maternal child health outcomes. Like I said, we have two amazing superstars. I want to just get right into it. And my first question will actually be for the both of you. I wanted to, sorry if you guys heard that sound. I wanted to know, well, first, Andre, could you please start by sharing a little bit about New Jersey's path to launching Family Connect in New Jersey for those that aren't familiar with it? If you could highlight what you've learned since implementation began, where the service currently afforded, and where it's expanding to next, that would be wonderful.
Yeah, definitely, Max. I see a lot of familiar faces in the chat, so I know many of you have heard or are involved with Family Connects New Jersey. But just for a quick overview and sort of background on where we've been going to date. The legislation that supports Family Connects New Jersey was signed into law by Governor Murphy in 2021. And so the first few years after the legislation was signed, DCF was assigned responsibility for building the program. So those first few years after it was the legislation was signed, we were really focused on making sure we were setting up the structure of the program to be consistent with the requirements of the law. But we also wanted to make sure that we really took advantage of all of the maternal child health and early childhood infrastructure that's already in place in New Jersey. We have a lot available here that isn't necessarily available in other states. And so we didn't want to recreate that. We wanted to build on what was already there and try to make the most of it and lift everything up. In that introductory period, we also had the opportunity to learn a lot and gather a lot of information to help us with the program design. So there was a pilot of Family Connects done in Mercer County in cooperation with the Central Jersey Family Health Consortium and Trenton Health Team. We had an advisory group with stakeholders and parents from all around the state. We, with the partnership of the Burke Foundation, were able to have a professional communications firm that helped us do some market research and surveys and focus groups and interviews to hear from residents of New Jersey about what would be important in the program, and also to get a professional workforce analysis of the nursing workforce in New Jersey. So we knew from the start that nurse workforce was going to be an issue for us, right? There's a nurse shortage in New Jersey, as there is everywhere else. And even more importantly, since the feedback we received and we knew already in our heart, we needed to have a nurse workforce that was culturally congruent with the families we would be serving. There's really a mismatch between the nurse workforce in New Jersey and the birthing family makeup in New Jersey. And so we were really going to need to be very intentional in our decisions and our efforts to hire, to recruit, to build out the program to allow for the growth of that workforce. And finally, messaging was something that really came out early on, thinking about how we present this program so people understand it's something for everyone. Unlike a lot of programs that we do at the Department of Children and Families where we're targeting specific groups that are in need, this is a universal program. It's intended for everyone, regardless of their income, their insurance status, their immigration status, their education level. It's really something where we want every family welcoming a newborn in New Jersey, whether that's a birth family, an adoptive family, a resource parent, someone who's experienced a stillbirth or a neonatal loss. All of those families have the advantage of having this service. The earliest piece that we were able to get in place was in state fiscal year 2023. We received an appropriation to start up the community alignment portion of the program. And so the most visible piece of Family Connects is that nurse home visit, but the nurses can't do the work that they do without the work of our community alignment specialists, some of whom I know are on the call today. And they are really the ones that build those relationships in the community, that build a sort of curated directory of resources that the nurses refer families to. When we have an unusual thing that families need that isn't in the directory, they're hunting it down, they're spreading the word about the program in the community. And we station those community alignment specialists at our connecting NJ hubs, which already exist in all 21 counties in New Jersey. So there are today, and have been since 2023, community alignment specialists working in all 21 counties of New Jersey. For the nurse home visits, we knew we had to take that a little slower because that was going to be a bit more of a challenge. And so we planned a phased rollout for the nurse home visits. So we started in January of 2024 in 5 counties: Essex, Middlesex, Mercer, Cumberland, and Gloucester. We did the procurement for who would be providing the services up front. So the 3 maternal health consortia are the nurse providers at the local level, and each have counties assigned to them. In January of this year, we added 6 additional counties, and so I'm going to look at my list so I don't make mistakes here. Sussex, Passaic, Bergen, Hudson, Somerset, and Ocean launched this year in January 2025. Next January, we will be launching 6 more, primarily in the South: Monmouth, Camden, Salem, Burlington, Atlantic, and Cape May. And then if all goes well, in January 2027, we should be launching our final 4 counties, and we'll finally be statewide with our nurse visits. Since launching, I think the key takeaway, people are receiving the program very positively. We talk all the time, presentations with community partners, health organizations, anyone that will listen to me and my team talk about Family Connects. They receive it very positively. They want to help us. And the families that are receiving the service are very positive about the service they're receiving. But we obviously aren't reaching the volume of families. We have a long way to go to get to that universal reach, I guess is what I'm saying. And so we're continuing to examine how we reach families in the best ways to get to them. But I think overall, I'm so pleased with the work that's been done so far. This has been really the highlight of my career to work on this program. And we have really the A team, both at the state level here at DCF and with our community partners working on this. And I'm just really excited and happy about the work that's happened so far, and I'm looking very much forward to what's to come as we continue to grow the program.
Thank you so much for sharing. And I'm really happy to hear that this is now considered like a highlight of your career. The work that you guys are doing is imperative and it makes a huge difference. And it's great to hear that the goal is to, within the next 2 years, have it statewide. So that was wonderful. Thank you so much. Jenny, could you please tell us about a home visit that really stayed with you, one that illustrates the kind of impact Family Connect can have for families in those early postpartum weeks?
Absolutely. And I'm so proud to be here. And I did want to take a moment. I'm really a nurse administrator, and I really want to acknowledge, especially there's so many members of the Family Connects New Jersey family that are here. And so I really want to acknowledge that I'm representing their really hard work and being out in the community. And so it is an honor to be able to share a story on behalf of that team that is statewide. And some of them are here listening in, some of them are out at visits at the moment. So again, just want to thank you for being able to be here and represent the hard work of our teams and what we're so proud of. So I know many folks have heard about the traditional Family Connects visit, and I wanted to take an opportunity to really highlight a visit that is not something that you hear about all the time. Particularly was for a family whose baby was in the NICU. So they had just experienced an unexpected preterm birth of their baby. They were enrolled into the program at the bedside by one of our program support specialists, Leary. And so they had enrolled in the program and set up an appointment with one of our home visiting nurses. The first visit with this family is what we call the initial home visit, was done just with the parents at home because their baby was still in NICU at that time. And so they received as much of the visit as they could without the baby portion. And some of that involved some follow-up for some preeclampsia. So for the birthing parent, there was more of a physical assessment, but really a check-in on how they were doing overall. The nurse had acknowledged that both parents seemed pretty anxious, and especially the mother of the baby really wanted to get back to the hospital and almost seemed like a little rushed, that she appreciated the visit, but really wanted to get back with her baby. So they were able to complete that visit and provide some resources. And she told her, we'll get in touch in about a week or so and see how you're doing. So after about a week, our nurse did a follow-up phone call to the family. Baby was still in NICU and having some improvement. And so our nurse offered a follow-up visit to that family and said, offered to meet them in the NICU with their baby. So instead of having the follow-up visit at home, she said, I know you've been spending a lot of time there. I'd love to meet the baby, and let's talk about, what the transition back to home is going to be like. And so the parents were thrilled with that opportunity, and they were really grateful for the nurse's flexibility. And so about a week later after that, she did meet them in the NICU and was able to, talk with the parents, meet the baby. She was able to communicate with the NICU nurse a little bit about what the transition of care was going to look like. And again, it was just a wonderful touch point for the parents. She could tell they were so much more at ease and relieved to be able to, spend time with them all together in the hospital. And then finally, about 2 weeks after that visit in NICU, they had a third and final visit when their baby was discharged home. And so everyone was reunited again. And so it was sort of like a final touch point. How's everybody doing at home? How's feeding going? How's the baby's weight and the continued progress? Have you been able to get back and see your pediatrician now that you're discharged? So it was just a really great opportunity to provide really wraparound care, and it extended a little bit longer than our typical care does since this baby was in NICU. But I just really appreciated the nurse being innovative and really flexible and wanting to support the family in the best way possible. Another opportunity I'll call out is that our program is serving families that experience loss, stillbirth, and neonatal loss. And there are not many other programs that are doing that. And so the idea that a registered nurse is going to the home to check in on families and provide some support, physically meeting them where they're at. We know many of these families sort of drop off the radar after they get discharged from the family. Some of the traditional support programs that exist out there might no longer serve them because they don't have a living baby. And so the fact that this program is serving those families, I think it really needs to be called out at any opportunity that we can, because we know these families need so much support. One thing that we try to do is, if the family has experienced a loss, we would order some sort of a memory item. We have a sort of a short list of different items that we would bring with us. Could be like something that they hang on their window, like a wind, or outside, like a wind chime. And any type of, item. Sometimes we order it after the first visit so that we see how they're doing, and maybe something that they would be of interest in. But again, I just want to call that out. It's certainly hard work. We try to protect the time of the nurse that day so that they don't feel rushed, so that they don't have to run to another visit afterwards, because we know it can be emotionally challenging for everyone. But they're really just doing really great work to support these families, in addition to the many families with well families and well babies going home.
Thank you so much for sharing. That was wonderful to hear the compassion that the nurse had to notice that the mother was feeling anxious about being away from her child, and then being so proactive to then be like, let me take a step further and meet you at the NICU. Let me help you here. And I imagine that's the type of nurse that would be able to pinpoint if something was going on mentally with their patient, because they're so intuitive. It's kind of like Lisa said, they took the 7 seconds needed to acknowledge their patient and to acknowledge the need, even though she wasn't there physically in person, even over the phone. She's taking the step to kind of see her or see this birthing person as a whole individual. And I thought that was wonderful. I do have a question for the both of you, now that you both have shared kind of like the work that you guys do in this space. How can we strengthen integration between Family Connect and other postpartum care efforts across the state?
I'm gonna let Jenny start.
So I would say I have a very ideal scenario that I think would make this a lot more integrated. So we've heard from providers that, they want to refer their families into the program, but sometimes they don't always realize the full picture of, what they're referring them into, and they would love to get feedback about how it's going. We're certainly referring a lot of families back to their OB or PEDS provider if there's a problem. But we know that, sometimes we're doing a good check-in and everything is well, and we know that they're going to follow up. But providers would like to hear that information as well. So I'm not a tech person, I'm a nurse, but I would love to have an easy way to seamlessly provide an after visit summary to providers. Ideally one that would come from our charting system, and that we could send that over as soon as we complete the visit and the nurse does their documentation. If we noted any resources or education that was provided, to just click a button and be able to send that over to, like I said, the primary OB or pediatrician. I think that would give feedback about how the family's doing, but it would really sort of just support that continuum of care. They're seeing them in the hospital, we're seeing them within those 2 weeks at home, then we're sending them back to make sure they're going for their scheduled checkups, their OB postpartum, or their scheduled peds. And so we could all be easily in communication about how everything's going. Perhaps we need to go for a follow-up visit for a weight check or something like that. So I know it's being worked on, and it's one of those things where we're working with all different EMR systems and documentation systems. So I know someone somewhere is going to get this done, but that would be my request, to really integrate what Family Connects is doing into the overall postpartum care system.
So definitely what Jenny's talking about is something that we're working on. I think the charting system we're required to use by the evidence-based model is really not in a position to have automated integration yet. They just moved to a new platform, and I think we're probably a couple years away from being able to do that. But we've been trying to get ready for it. We've been having conversations with the folks that manage the HIN, so that hopefully we can build a way to exchange information, both to know that people have given birth and to give information back to their provider with the family's permission about the visit that they've had. Jenny makes a really good point, which is it's not only about what happened in the visit, where were things in the visit, but also what referrals were made. About 45% of the families we see get at least one referral to some sort of external something. And it would probably be helpful for their provider to have that information. And so in the meantime, we're working on something on paper that the family can share, that the nurse can complete during the visit, just to have the high points, and the family can choose to share that with their provider, so that there's a little summary of what happened and what the key takeaways were: infant weight, mother's blood pressure, referrals made. And then also give, hopefully that's a way to say to the provider, hey, there's this program, Family Connects, if you didn't know about it, here's some information about that, and a way to kind of expand our outreach about the program. We've also been working, this isn't exactly around postpartum care, but just thinking about that connection with healthcare. We've been working, and actually Jenny's team is the one that was the groundbreaker with this. They were working with Virtua, and were able to get connection in the electronic medical record at the hospital, so that when families gave birth at Virtua Voorhees but lived in Gloucester or Cumberland County, there would be a flag to the medical team to tell them about Family Connects. And based on that model, we've now been able to get that in place in 21 other hospitals around the state, and are working on 3 more. So our goal is to hopefully get it in place in every hospital, as well as some other things like including information about the program in the discharge packet. But I think opening the door to that integration in hospital systems, I think, is a real milestone for us, and we're really excited about the progress we've been making there.
That is wonderful. Thank you so much. I've never even thought of the concept of we need to make sure that our providers are better educated on Family Connect to ensure that people are getting referred to the right place. It makes sense. It's a system, and as long as each person continues to work within that system, is a team player, then I can see how people are getting access to better care overall. I have a final question for you two. As we look ahead, what improvements are you currently working on that would significantly enhance the reach of effectiveness of Family Connect in New Jersey?
So I'll get started, and we know it's really, really important to get this program out to every family in New Jersey. And the visits that we've had so far, about 17% of the families that we see have some sort of significant either maternal health concern, infant health concern, or caregiver well-being concern that requires immediate medical attention, whether that's a referral to the emergency department or a referral back to their provider. And often, in some cases, the nurses even facilitate getting them a quick appointment to make sure that care happens. So we know that this is a really valuable service for families. One of the things that we've done is we've been exploring how can we reach more families. We had a family engagement work group where we brought in people from all different communities around New Jersey and tried to look at what are we doing wrong with our approach to making this information available, and how can we make things better and easier for families. And so one thing we took away from that was having more material available in other languages. So again, with the help of the Burke Foundation, we've been able to get our outreach materials translated into over 20 languages. All of those are available on our website, so someone can go to our website and print our outreach material in over 20 languages. We have a video library right now in English and Spanish. Hopefully we'll have other languages potentially in the future. And another way that we've tried to make signing up for a visit more easy. Initially, families had to go to our website, complete a form, and then wait for a call back from the nurse provider to be able to schedule their visit. And so we've actually added a self-scheduling feature that allows families to pick their appointment right then and there on the website without having to wait for a call back. So that's both being used by families, and that same tool is able to be used by our teams when they're meeting with families in person and want to get them set up for a visit, so that we integrate that. And then there's, I think, a couple of things that Jenny wanted to talk about on this topic.
Yeah, so I would say for my team down in South Jersey, we know that bedside recruitment has been the most effective way to get families enrolled in the program. And we're really fortunate that we've had some really strong champions down here in the South. Specifically, Inspira and Virtua have just been wonderfully supportive and welcoming our staff. So essentially what that means is we have staff members that are approved to go into the hospital to see patients that are eligible for the program on the mother-baby floor, tell them about our program themselves, and be able to schedule them right there at the bedside. And we actually have a postcard with all of our nurses' faces, and they'll point and say, this is Tiffany, she's going to be your nurse, she's going to come see you at your home. So that has been the most effective. And I would say as we continue to expand, and for us down here in the South, we will have expanded to all of our 7 counties in January. Really just that relationship with the hospitals is going to be key to be able to offer this. We know that the hospital staff have so many things that they're already doing, that so many different education items to provide, and we don't want to add anything to that list. So giving us the opportunity to be the ones to represent our program and to actually schedule them, it's making it better for us with our enrollment, but it's of course supporting those clients and patients that deliver at those facilities. And we've put processes in place where they're reaching out to our staff saying, hey, we have 10 people getting discharged today that are eligible. Can you get here early in the morning so you can make sure you see them? And so some of that, communication and teamwork, because they recognize that this program is so valuable and they want their clients to have it. So they're willing to work with us, however we need to be flexible, and so that we can get their patients enrolled. And so I think the continued support, I'm confident with our facilities down here. All of the consortia have really strong partnerships with their birthing facilities. And so if we can make a way to navigate that process at each individual system of how we can get staff in and privileges to do the bedside recruitment, I know that that's just really going to help with implementation and enrolling more families.
Yeah, we've definitely seen an uptick in the amount of families that participate when we started doing bedside and bedside recruitment. I think originally we were hoping that the magic of digital marketing was going to get all of our families identified and get them signed up. But that was one of the things that we learned in that first year of implementation. And when Jenny's team put in place bedside recruitment in some places, we really saw that transform the number of families that were signing up. And so we've been working to get that in place all around the state. We've got 9 hospitals in place now, 7 more that we're working on. And as she said, as much as we can try to tackle that at a system level versus having to go hospital by hospital, that I think that would really help that go more smoothly, particularly when we start expanding into yet more counties. I think the other takeaway that we've had in terms of improvements is, and so this isn't really improvement, it's like continued more of, but recruiting and retaining staff that are culturally congruent. About 40% of our nurses, 42% of our staff overall are bilingual or multilingual, but we know there's more work to do in that area to again meet up with the birth population, and we very much appreciate being able to match families if we can. If they don't, we'll use translation services, but the visit is always going to be better when we can give someone who can speak their language. And then if it's not about a language issue, it's a cultural issue, wanting to make sure that we can be sensitive there as well. We train the nurses, but there's nothing like seeing a familiar face.
Yeah, no, that was wonderful. Thank you so much for sharing that. Hearing about adding language initiatives, just because New Jersey is such a diverse state, and then hearing that you guys are doing bedside recruitment sounds brilliant. It sounds like a great opportunity to really address when someone might need the program most. And it sounds like it's been going great for you guys. So thank you again for just sharing so much about Family Connect, sharing so much about the home family visit program, what you guys do for work, and how you help make a difference in the state of New Jersey. So thank you so much. I will now transition. We will now transition to our open Q&A session for all of the speakers. So I see that there are a lot of questions. Kate, would you like to facilitate, or would you like me to?
Yeah, I've been taking note of a few questions. So the first one, I will toss it over to Jenny. We have the question that came in, is there an age limit for nurses to be hired for Connecting NJ?
Oh, that's an easy one. No age limit at all for our Family Connects nurses. We certainly appreciate the many years of experience. And so no age limit at all. We are hiring registered nurses or advanced practice nurses, either one. And it certainly helps when the nurses are from the communities that they're serving, that they're familiar with, where the supermarket is, where that family might be going to, or they have their own, ties and they're invested in the overall health and well-being of that county. That certainly helps. And we appreciate that we've been able to build teams that really reflect the community that we're serving. And I think that as well as some maternal child health experience is definitely the priority for us and for me as a hiring administrator.
Thank you. And so all of you nurses out there who are looking for a new role, I saw that the job postings were just dropped in the chat. So please feel free to share widely with your community and your networks. I have a question that I think came in during our first panel on mental health, but I really do think probably applies to any of our speakers who wanna yield it. Have there been tangible resources or work that's been done alongside doulas or other home visitors that have helped spread information and support either for mental health screening and care, or lactation consultant, or linking families to Family Connects? What has been the role of doulas alongside all of you? Anyone can jump in.
I don't know of anything specific to maternal mental health. I know that I, as a L&D postpartum nurse, refer people to postpartum doulas constantly for sleep support. So I'm filling up at least 2 agencies here in Ocean County and believe firmly in the village, women supporting women who would know better, whether it's prenatal or postpartum. And I think that there was an open training program in Ocean County for 12 community women to be trained for free to become postpartum doulas through a grant.
Awesome. Thanks, Lisa. Do any of our other speakers want to yield that question?
I would say from Family Connect's perspective that we are definitely open to partnering with doulas and working with doulas. We don't see it as an either or, but a both and in terms of the benefit that doulas can bring to the family and the benefits that our programs can bring to a family. In terms of mental health screening, I will note that as part of the Family Connect's visit, which is about I'd say an hour and a half to 2 hour long visit, typically with most families, they do screening for depression and anxiety, as well as a host of other things that Jenny could speak more on. But just to want you to know that part of the things that the nurses are screening for is looking for mood disorders. So that's something that we would make connections for the family if we found that there was a concern for the birthing parent or for their partner if the partner is part of the visit.
And the breastfeeding strategic plan project, of course, we've always had active involvement and partnership with doulas, who are incredibly important, of course, with supporting breastfeeding prenatally and during the postpartum period. And we look forward to continued work with the doulas and also to bolster and help in any ways we can with lactation-related education and for the doula programs.
Oh, I can ask a question. This is one that this is to the entire group, but it's a question that I typically like to ask. So if we were to redesign New Jersey's maternal health system from the ground up with equity as the starting point, not the afterthought, what would be non-negotiable elements for you? Where do we begin to make that vision real within our current constraints?
I can kick it off by saying that we recognize we need a much more diverse lactation support workforce, and Felicia touched on that and can add more to that. We would definitely be we're looking for more opportunities. The Breastfeeding Strategic Plan Project hopes to work with Maternal and Infant Health Innovation Center, which has planned program for education for lactation support providers. But another thing we sorely need is more clinical placements in the state to train clinical lactation care providers. We're really short on them. And even if we can fund the education and really be able to increase, I mean, there's so many people interested. Every time I go out to speak, people come up to me and say, how can I become a lactation counselor? How can I become a lactation consultant? As a state, we need to prioritize resources and funding for that. But once we get everyone educated, we do need those sort of hands-on experiences as well. And we're working with hospitals and other organizations around the state to do that so that we can provide enough education, particularly for more diverse workforce, lactation workforce.
Yeah, I would agree with Ellen. And then more opportunities at community-based organizations. So grants, community organizations writing grants for lactation consultant and a lactation consultant, a CLC, to be at that agency for those families. So when they are getting resources and they have an infant and they are breastfeeding, that they can see that lactation consultant. Also too, like Family Connects program, integrating a lactation consultant on staff to help troubleshoot some of those questions that families have. Home visitation programs, your healthy families, your nurse family partnership, partnering with those programs and having a lactation consultant on staff to, troubleshoot and help, or multiple or CLCs on staff to kind of go out with the nurse. So that everything is not burdened on the nurse. And then also the doula programs, same thing, integrating lactation into that and having a lactation consultant involved in those doula programs so that they can troubleshoot, go out to the homes with those doulas, spend some time with those families in those settings so that they're getting that lactation education before prenatally while a doula is working with them. Maybe it's two sessions that they get one-on-one with the lactation consultant, and then they may get 1 or 2 after postpartum, but they, that lactation has been a touch point with the lactation consultant instead of the doula. Now postpartum is like, okay, I need to refer you or need to see, do you have insurance? Would the insurance accept the lactation? If the program just integrate lactation into it, then those touch points are already met. Same thing with the perinatal mood disorders. If we talked about social workers being trained, so then having that person on staff, right? That way, families are getting all of the support right there at that agency. We're not now sending them to another agency and making it another barrier if they don't have transportation. So yeah.
I would like to get on Jenny's plan of systemic EMR availability, since we're starting out with money and having every person physically and mentally equal at any doctor's office, and give them the glucose test or regular visits, screen them by risk factor for their opportunity to get perinatal mood disorders, and forward that information in that great network to a clearinghouse, who would then be able to Spider-Man web it out to the right county, knowing that we were landing, that there was someone, a person, doula, like you're saying, breastfeeding, we work hand in hand, but that there was this team, and it didn't fall on one doctor or pediatrician or nurse, that we could confidently be like, hold on, let me get you somebody, since we have money.
I can share that throughout the Family Connects New Jersey program in the state, we have many IBCLCs, CLCs, and CBCs throughout the teams, which has been incredible and super, super helpful when we know that feeding concerns or questions is often the top priority of a family when they're getting discharged, especially if it's their first child or if they've experienced challenges feeding with a previous pregnancy and now they're already anticipating, okay, this might be challenging for me again. I will say that down south, if the family is identifying at the bedside to our program support specialist that they already are thinking about these feeding concerns, we try to be intentional with sending a nurse, although they are all trained to support with breastfeeding, but we can be sometimes strategic with who we're sending to the house, particularly if we know that they might be already experiencing some issues. And we've also sent 2 nurses to a home, like when we go to serve multiples or if there are other challenges, just to provide as much support as we can. So that is part of our standard visit, and we're very fortunate to have those certifications and trainings on our team. If to answer the question about building from the ground up, I really think kind of sort of what you mentioned, Felicia and Lisa, is like really integrated care. And for me, like I would see that every office is modeled with family practice, OB, phlebotomy, and so for a family that has young children and they're trying to get to an appointment that they can bring their children with them without concern about that, that if at that time the provider orders labs, they can just, wait for the phlebotomist to come in and take their labs right there in the room, that we don't have to ask them to go to a different building, because we know that that is challenging for people with transportation and resources. It's hard to get all those things done. So really, I think an integrated care model, if I had to build it from the ground up, and that they would see their social worker there, they would see their mental health provider, that there would be options for a group at lunchtime. I know they can't spend the whole day there, but that for the day that they make it there, that they can get everything that they need in one place where they're comfortable, where they've built trust and rapport with the people that are there. I think that would be the best if we could restart it, that it would all look like that.
Yeah, thank you, Jenny. That has been my desire for years now. So it's so good to hear someone else is on that too.
Yeah, no, I don't know if anyone, oh, Lisa, did you want to say something?
Well, no, I mean, I just want to be in the same house as them. I think having everything in one place is like, duh, again, and just so available and would open so many opportunities for a conversation with someone who was in the right place with the right people and be so preventative and validating. I mean, I'm coming there.
Yeah, no, I mean, just hearing, I love that that Jenny mentioned integrated health. The Quality Institute has actually been doing some work on educating on the new regulations that the state has brought out for that. So if anyone's interested in that, we do have that video, and we can share that with you. And I think, well, before we wrap it up, I just wanted to say thank you again for taking the time to share your expertise in this field. Hearing that postpartum doesn't just begin after birth, but really just like even before someone gets pregnant, that family planning is important. That initial, intentionality is so imperative to ensuring that someone is going to be safe. And Dr. Lamborn highlighted health disparities and racial disparities, and how that can impact people. We talked about educating providers about Family Connect programs and doing bedside recruitment to better roll out programs like that. So it's wonderful to see that the state of New Jersey has these amazing programs and that has these amazing superstars such as yourselves doing the type of work that is necessary to ensure that we can reduce the rates of maternal mortality. Looking at Lisa's PowerPoint, seeing that maternal mortality, one of the highest rates for that is self-induced suicide. And so that is so sad to see because we need to provide resources to people. And Jenny highlighted giving bereavement services. Ellen and Felicia talked about making sure that families, specifically families of color, have access to lactation consultants. And so you all did phenomenal. Thank you so, so much. And then I will pass it on to Kate to give some closing remarks and our next steps.
Thank you so much, Max. And I echo everything that you said, that this was an incredible hour and 49 minutes to date. Just hearing from you all and the links between all of the work that you do and all of the work that we collectively can be doing together to just bring wellness and health and care to birthing people, new parents, and families living in New Jersey. So thank you so much. And thanks to all of you who have participated today. We know this is a large chunk of time to take away from your day. And if you're anything like me, your stomachs are growling, you're ready to maybe see the sun, which is out for the first time in what feels like months. And so we thank you so much for joining us. We do have a number of upcoming Quality Institute events, including, drumroll please, back with popular demand, our in-person MAP conference, which will be taking place September 10th. Save the date. More information will be coming out about that shortly, and we'll be sure to get that sign up for that free conference available to you all as soon as we can. Additionally, this recording, as well as our PowerPoint slides from our first speakers, will be shared via email and will include links to all of our events. And I see that Vanessa dropped that in our chat as well. So thank you so much. We hope you all have a wonderful afternoon, and we appreciate your time with us today.